Apexogenesis and apexification. The root formation of permanent teeth takes place 3 years after eruption of the permanent teeth in the oral cavity. This is a generalized rule. For example, if the permanent molar erupts at the age of 6 years, the root will be formed at the age completely in 6 plus 3, that is 9 years. So, meanwhile, if there is any trauma or infection to the pulp of the permanent teeth or this young permanent teeth, it will be leading to the inability of the formation of root or incomplete root formation or incomplete closure of apex of the root of permanent tooth or the young permanent tooth. So if so, it is there. The incompletely formed roots can either be divided into a blunderbuss canal and a non-blunderbuss canal. Now what is a blunderbuss canal? If the root canal is funnel shaped, that is, the coronal part of the root is narrower whereas the apical part is wider, it will be called as a blunderbuss canal. But in a non-blunderbuss canal, the coronal part is wider than the apical part. That is, it will be an inverted funnel shape. Either the walls can also be parallel, that is, the coronal part will be equal to that of the apical part in diameter. So if such takes place or if the tooth is traumatized or infected during the process of its development, then in such teeth endodontic treatment is necessary. So what type of endodontic treatment is undertaken in such infected or traumatized teeth? In such teeth, there are certain difficulties which can be encountered during the endodontic treatment. This is because there is no hard tissue stoppage which is present at the apical region. So it will be difficult for condensation of the gutta percha points towards the apical portion. So the obturation will be very difficult in such cases. Even there are chances for the permanent root to fracture because they are very thin and fragile. So the pulpal treatment modalities for such type of teeth are modified a little. They can either be divided into conservative treatment and radical treatment. The conservative treatment, they incorporate vital pulp treatment, and the non-vital pulp treatment include the radical pulp treatment. They can either be classified into the indirect pulp capping, which is direct, pulpotomy, and apexogenesis, which constitutes the conservative management of pulp therapy for such teeth. And the radical management includes pulpectomy and apexification. Now let us see what is the exact difference between apexogenesis and apexification. Now apexogenesis, it is generally undertaken in vital permanent teeth. That is, the pulp is not infected up to the necrotic level. The infection in the pulp is minimal. So it can be treated by the process of either indirect pulp capping, direct pulp capping, pulpotomy, or apexogenesis. So in apexogenesis, basically there's a physiological process of development of root by a vital means. In apexogenesis, generally the normal root development takes place. In such cases, Hardwick epithelial root sheet may be present. But in the cases of apexification, generally there is an indication or induction of the root end development, and the material which is formed at the root end will be resembling a cementoid or the osteoid in nature. It will also appear as a Swiss cheese appearance. In apexification, the pulp chamber is entirely necrotic, and it is a case of irreversible pulpal necrosis. Normally, the root development does not take place physiologically, but there is a pathological induction of the pulpal end or the root end development. A calcific barrier is formed clinically and radiographically as well. That is, the calcific barrier can be appreciated in the radiographs. So, basically in apexification, osteocementum type of material will be deposited at the apex. So let us know that what basically apexogenesis is. Apexogenesis is the treatment of vital young permanent tooth by the process of capping. This is the process of physiological root end development, in which the root is developed slowly but by the mechanism of physiological process. That is, the natural defense mechanisms of the tooth and the surrounding structures will lay down a structure at the apex which will work as a barrier. So basically, apexogenesis can be defined as the treatment of vital tooth by either capping or pulpotomy so that the physiological root end development takes place. The main objectives of the same are is to remove any infected radicular or coronal pulp which is present and further to preserve the vitality of the radicular pulp. The rationale of apexogenesis is to maintain the integrity of the radicular pulp which is vital to maintain any Hartwig epithelial sheets cells which are present in the radicular portion and to remove the infected coronal pulp or the inflamed pulp which is present in the tooth. Moreover, it also helps in maintaining the tooth in a non-pathological or a physiological condition in the oral cavity so that the proper root end closure or root end development or apical closure is obtained. The major indications for the process of apexification is that the tooth should not have any history of spontaneous pain or any bleeding from the site or any pain on percussion. The tooth should also not have any periapical radiolucency or enlargement of the lamina dura or obliteration of the space. The tooth should be vital and should not have any signs of non-vital tooth. The major contraindications for the same are if the patient is having a spontaneous pain or a nocturnal pain or the purulent discharge or pus which is present in the pus chamber, the pulpal chamber. Then if there is a history of prolonged pain, that is, even if after the stimulus is removed, the patient is also complaining of pain still. If there are necrotic debris in the canal of the pulp or any periapical radiolucency which can be appreciated radiographically. In such cases, we go for apexification rather than apexogenesis because all these are indications of an irreversibly damaged pulp or the pulpal necrosis. The basic materials which are used for the purpose of apexogenesis are calcium hydroxide, zinc oxide eugenol, mineral trioxide aggregate, the bone morphogenic protein, the osteogenic protein, freeze-dried collagen, enriched collagen, then electrosurgery or electrocautery and laser type of apexogenesis is also used. Now coming over to the step-by-step procedure for apexogenesis. First of all, administration of local anesthesia followed by the placement of rubber dam should be done for the purpose of isolation. All the carious debris should be removed from the tooth and the access should be obtained in the tooth structure. The chamber of the pulp is opened and the removal of the entire necrotic coronal pulp should be done. After removing of the necrotic coronal pulp, the debris of the pulp should be removed. So after opening of the pulpal chamber, all the debris from the pulpal chamber of the pulpal tags are removed by the means of a sharp spoon excavator or a slow speed burr. Then all the debris are rinsed by the means of an irrigating solution and the hemorrhage is controlled from the site by the means of a moist cotton pellet which should be placed over the amputated pulp stumps. Further, after the hemorrhage is cessated or stopped, a mixture of calcium hydroxide slurry is placed over the pulpal stumps, followed by placement of a temporary restoration. Furthermore, follow-up radiographs should be taken periodically to check the root end development. The patient should be recalled from 3 to 6 to 12 months and all the radiographs should be kept in record for the purpose of the evaluation of the root end development and the root end closure. Once the root development is complete, the conventional root canal treatment can be done and the canal can be obturated by a permanent tooth obturating material, that is gutta percha. Even thermoplasticized gutta percha can be used in the same. So this is a picture in which we can see that calcific barrier is obtained by placing a calcium hydroxide slurry over a period of time, and finally the restoration is done and the crown even could also be placed in the tooth. Advancing further to apexification. Apexification is the method of inducing root end closure by the formation of a mineralized tissue in the apical region in a non-vital young permanent tooth with incompletely formed root. So, the basic indications of the apexification procedure is that the tooth should be non-vital and should have an open apex or blunderbuss canals. The objectives of apexification procedure is to induce the root end barrier at the present of the open apex and formation of the calcific barrier at that site. Furthermore, there should be no evidence of any abnormal calcification in the canal, internal or external resorption. Even lateral periodontal pathosis or lateral abscess or cyst should be absent. The radiographic breakdown of the lateral periodontal tissue during or pre the treatment should not be present. The various rationales for the treatment are the reactivation of the undamaged or the vital pulp tissue, which is residual, then reactivation of the odontoblastic layer, which will further lay out the osteoid matrix, the reactivation of the Hartwig epithelial root sheath, which will help in the root end formation. Even if after the osteoid barrier is obtained, it can be of a Swiss cheese type of configuration. The materials used for the apexification procedure are zinc oxide eugenol, metacrysyl acetylate, camphorated parachlorophenol, tricalcium phosphate and beta tricalcium phosphate, then resorbable tricalcium phosphate, collagen, calcium hydroxide and mineral trioxide aggregate. The treatment of apexification can be divided into three types. It can be either the surgical treatment or apexification by the means of formation of an apical barrier or apical closure, which is one of the most widely accepted technique. Then Furthermore, the formation of an apical barrier technique. Now we'll be discussing all these techniques in detail. The surgical technique is one of the most oldest techniques. It is usually an approach of treating pulpless teeth or young permanent teeth with widely open immature apices. The procedure for the same is that by the means of opening the flap, the tooth will be exposed. Then the root can be retrogradely cut and filled by an obturating material. If a bony defect is present, we can also incorporate the osteogenic materials or bone graft materials in that space, and then furthermore close the flap which is present. This is a surgical technique, but the main disadvantage of the same is non-compliance of the patient or some psychological effect on the patient may be present. It is also difficult to achieve for the personnel or for the operator. Then it can also lead to the compromising of the crown root ratio, or the crown root ratio becomes smaller or poorer. This will help in further prognosis of the teeth. Now, what is the technique of apexification? Before starting apexification procedure, the preoperative assessment is mandatory. That is, clinically evaluation of the color, mobility, tenderness and swelling of the periapical radiograph should be evaluated. When all the acute signs and the symptoms are absent, the instrumentation is recommended. Then application of rubber dam is followed by application of anesthesia. Furthermore, access is gained in the pulpal chamber and the barb broach is used to remove all the debris from the pulpal canals. Irrigation is performed by the means of saline or hypochlorite. The length of the canal is established by the means of working length preoperative radiograph. Now, in this step or in filing procedure, care should not be taken to file against the thin pulpal walls towards the radicular region or towards the apical region, because this may lead to fracture of the root. Sonic or ultrasonic instruments are used for debriding the canal. Liberal use of sodium hypochlorite to flushing out all the effervescent debris from the canal can also be used. Although the debridement of the canal is dry and just minimally with CMCP. If the symptoms persist or any signs of infections are there in the canal, a slurry of calcium hydroxide is sealed in the canal. Furthermore, the canal is dried and filled with a stiff mix of calcium hydroxide and CMCP paste. The paste can be carried out in the canal by the means of amalgam carrier, amalgam plugger, a lenturospilum, or a disposable syringe. Even endodontic pressure syringes can be pasted. Now, if there is overfilling of the material, we will assess that a successful apexification has taken place. Barium sulfate can also be added for the purpose of radio opacity. After the canal is filled with calcium hydroxide slurry, the orifice should be closed with a permanent filling material to prevent any micro leakage. The anterior teeth should be filled with a composite and the posterior teeth can be filled by amalgam. Finally, if required, the tooth can be restored by a stainless steel crown. Now, periodic recalls of the patient should be done from the period of 3 to 6 months, wherein we check for the formation of a calcific bridge, the continuous apical development, or there is absence of any internal resorption or any radiolucency which is present. The time which is achieved or required for the purpose of apexification is generally from 6 to 24 months and an average of 7 months, wherein the patient should be recalled and re-evaluated every 3 months. If there are any signs of infection, or necrosis present in the pulpal chamber, the entire filling is removed and refilled with a calcium hydroxide slurry or a paste, which is repacked. Further, if apical seal is obtained on verification by the means of a small instrument, the gutta percha points are obturated in the canal. If suppose the canal is very large, gutta percha points are fused to each other by the means of roll-on technique, wherein the GP points are fused to each other by heating a glass slab and rolling on together. The calcific barrier which is obtained can either be of osteoid type, that is, a bone-like matrix can be obtained, or a cementoid, that is, a cementum-like matrix can be obtained as an apical barrier. But there is absence of any Hartwig epithelial root sheath, which indicates that the normal root end formation cannot take place in the case of non-vital teeth. Finally, the canal and the root can be restored by the means of a crown. Now coming over to the apical barrier technique, the various medicaments which are used and are MTA, which is one of the most popular material. MTA is also called mineral trioxide aggregate, which was discovered by Torabinejad in the year 1993 of Loma Linda University. It is an alternative treatment and allows for immediate obturation of the canal. It has increased advantage of reduced costs, lesser number of appointments, better patient's compliance, and the sequel for the root fracture is also less because the thinner roots can be avoided. The materials used other are calcium hydroxide, tricalcium phosphate, and osteogenic protein. Now, what is the procedure underlying the same? Herein, we use or mix the MTA with a saline and a paste is obtained, which is further pushed by the means of amalgam plugger or by the means of endodontic pluggers into the apical region. Before this, a working length radiograph should be established, and all the steps before are the same. After placing of the apical barrier of mineral trioxide aggregate, a cotton pellet or a moist cotton pellet is sealed in the pulpal chamber. Thereafter, 24 hours the patient is recalled and the filling is re-evaluated, that is, if the apical barrier is not shifted. Furthermore, if the setting of the material is obtained, then we can obturate the canal by the means of gutta percha points and finally restore the tooth by the means of composite or other materials. Here we can see a case which is done for apexification. These are the various pictures. The material, that is mineral trioxide aggregate, which is mixed with saline and obtained in such a mass, which is obturated into the canal at the apical seal. And final restoration of the teeth is done. But what are the materials which can be used in obturating or final restoration? The restoration should be designed to strengthen the root after the obturation, because after the obturation the tooth can become brittle or will be more prone to fracture. The restoration can be done by the means of a light cured composite. Often a post which is clear and light activated can also be incorporated in the tooth. For this purpose, gutta perchas are removed. That is, only a apical plug or 5 to 6 mm should remain. This can be obtained by the means of Gates-Glidden drills. After this, a luminix post is selected and placed into the pulpal canal. The dentine is etched, bonding agent can be further applied, and the flowable composite is placed into the pulpal canal, which will be further light cured. Care should be taken that air bubbles should not be trapped into the composite filling. Finally, the post is placed and the composite is cured by the means of light. In apical barrier technique using MTA, generally it is not necessary to use GP points, for the canals can also be obturated with a composite resin. But the prognosis for the root end development in the tooth for apexification is less, or it is poor, because the tooth is fragile and is more prone to fracture from minimum trauma. There are certain criteria for the apexification which were reported by Frank, which are also called as Frank's criteria for apexification. They are: if there is a radiographic evidence of a calcific barrier at the apex, this is the criteria number 1. There is a criteria number 2 which indicates that if there is instrumentation of the apical region, it will help in detecting the apical stop at that region. Then criterion number 3 denotes that there is minimum recession of the canal space, but the apex is closed. Criterion number 4, it denotes that there is no change in the root canal space, but the apex is found to be closed. So, a primary tooth can act as a best space maintainer, and it needs to be retained in the cavity if it is infected. The updated knowledge and advanced techniques should be known by a pedodontist or a dental professional in order to accomplish pulpal therapy and saving the primary teeth to prevent any sequel from the loss of primary teeth, or to prevent the tooth from getting extracted and maintain the tooth in a healthy state in the oral cavity. Thank you.